All right, welcome everyone to this EMCT podcast on the topic of onboarding in emergency medicine. We have a very special guest today, Dr. Sean Michael, who I've been waiting, what's it been, about a year to get together and talk about this. And he is from the Centers for Medicare and Medicaid Services, CMS for short. We'll be hearing that a lot during this discussion. And welcome to this discussion, Sean.
Thanks, Steve. Yeah, I really appreciate you getting together. It has been a long time coming, and really excited to be able to talk about CMS's work in this area and a lot of our mutual interests with the rural and clinical communities and making care better everywhere.
Cool. Yeah, and just for everyone's sake, we don't call each other Doctor this and Doctor that in person when we're talking, and this is kind of a discussion that we want everyone to be part of. And it sounds informal, but actually we're talking about really important topics, and I don't want to diminish that with how we may make it sound informal, but it's still light, and we're friends and colleagues, all of us, and so we'll treat it as such. So, Sean, with other topics that we've covered in this podcast series, I've talked with healthcare leaders from large health systems, people that provide additional services to improve care in rural communities, which is really our focus today, not just onboarding in general, but really how do we improve care in rural communities. And so I've talked with advocacy organizations through ACEP for physicians and all, but also through SEMPA for PAs and AEMP for NPs and family and primary care organizations, as well as to how we can improve care. And we'll kind of peel back the layers of that onion and get to the core of what really a strategy could be going forward, and how CMS can be and is being integral in helping in that process. But first, before we get too far down that path, as a board certified emergency physician, how did you get interested in policy, and how did you find your way to CMS? I mean, the emergency medicine just such a broad field, and I've taken advantage certainly of some of the luxuries of doing things outside of clinical work in the ER. But how about yourself? What was that path that brought you there?
I never would have imagined this a number of years ago. It's one of those journeys where, as you said, we have the opportunity in emergency medicine to sort of see the full spectrum of healthcare. We have the pleasure of caring for people sort of 24/7, 365, and as circumstances arise on their worst day, or sometimes around their best day, depending upon the circumstance, right? And it's something where we're in a very privileged position clinically, but also we see all of the pieces of the healthcare system at this really interesting nexus point where outpatient and ambulatory care and inpatient care come together, where acute episodic unscheduled care needs show up, where we see the failings and the holes in the rest of the safety net in the healthcare system that show up at our doorstep. So a lot of those experiences, through training and through my clinical practice, led me pretty early into this idea of working on the system as well as working in the system. And I ended up with great mentorship early on in residency that led me onto this path of doing an administrative and operations fellowship, and had a experience across a number of different EDs in various parts of the country, learning from different leadership teams and learning about the sort of business of medicine and learning about the quality management practices and everything else that sort of goes into what sometimes as frontline clinicians, sometimes we think of as behind the scenes, but actually is really the fabric with which we are working. It's very hard to disentangle sort of the patient care one-on-one interactions with the system in which we practice. And so learning a lot about that system in which we practice, came back. I'm originally from Colorado and sort of went away for residency in Detroit at Detroit Receiving and fellowship at University of Massachusetts, and came back to Colorado. Was on faculty, still am on faculty at University of Colorado, was the ED medical director there for a number of years prior to coming to CMS. And similar to the sort of arrival at the point of realizing that I really wanted to work on developing, enhancing, improving sort of the local systems of emergency care, had the same sort of draw toward the national systems of care generally, not beyond just emergency care too, right? But all of the underpinnings of how our health system works have always been super interesting. And very fortuitously, sort of one conversation led to another. And in 2022, had the opportunity to come to CMS. And so I still practice clinically about a day a week on average. And the rest of my time is with CMS. We work across all the different program and policy areas, Medicare, Medicaid, Marketplace, and all the other things that people sometimes don't think of as associated with CMS, like CLIA, laboratory regulation. EMTALA is obviously a big one within the emergency medicine space that we know about, hospital price transparency, and hundreds of other things, lots of these different policy areas where something attaches to CMS in some way. So I'm in this very privileged cross-cutting role across the agency, get to work with people who have this amazing depth of expertise in all of these different places across our agency and across Health and Human Services and federal government generally. To be able to sort of tie things together, understand what's going on the front lines, translate what's happening in the policy sphere to figure out what the on-the-ground implications are going to be. And I'll end the intro sort of where you started it, actually, which is that we sometimes, certainly as frontline folks out there, see CMS as this three-letter government monolithic agency that we can't quite see into. And a lot of my job, and I have 4 wonderful colleagues around the country, and we've just added a 5th who are these regional chief medical officers. So we're geographically distributed, but we all work together across the country to work across national policy stuff and local and regional issues. And that group of us really are out there representing the agency to clinicians. We really do want to be on a first name basis with clinicians around the country. We want to be the friendly face. We want to, defy the stereotypes of the agency and be a person so that people can call Sean and figure out, what is the agency thinking about this? Or did you know this is happening out here? Or what do we do about this? And really be a human who is sitting at the intersection of where clinical practice happens and where policy happens, to be able to help be a knowledge broker and bridge some of that divide.
Well, and our communication in the last year, I can tell you, has changed my impression of it as well. I mean, it's a bit of an enigma, or it's just this organization that's out there as a governing body, and it seems very impersonal, and you make it very personal. And the staff you work with, just the relationship you talk about, sounds like they're people really trying to do their best to implement policy. And speaking of that, it really comes down legislatively, right? I mean, CMS isn't a body in and of itself that is governing healthcare or the Medicare, Medicaid, and CHIPS program, which fall under CMS. It's really driven by Congress, right? And you have to follow legislative mandates and get budgets for certain programs and that sort of thing. Does that kind of reflect it? And how do you go about then advocating from the ground up when you hear of issues? What is that process? I know it takes a long time.
Yeah, it definitely takes a long time. I mean, that's exactly
process?
right. Yeah, it's a great question, and it's exactly right. The way it's the experience, being a relative newbie to federal government has been a wonderful civics lesson for me personally also, and sort of how our government and how our structures and processes work as well. And to be able to see that from a different perspective than I did before has been really helpful. And the way that the interconnectedness between legislation, right, and Congress, certainly the federal level, Congress, through statute, makes appropriations of money. They create programs. They often set, sometimes with very specific detail and sometimes with more general detail, and they sort of delegate authority to a federal agency, but they set sort of the parameters and guardrails. And so, as we'll talk about in more detail later, right, rural emergency hospitals or critical access hospitals, or how the prospective payment system works in PPS hospitals, all of those things sort of are created by Congress, as you said, and have some of the details sort of baked into the legislation, but oftentimes require a lot more detailed implementing regulations, and sometimes to figure out the specific details of how to run the programs day to day, and how to take the money that is, right, it's all of our money. It's the American taxpayers' dollars that we're investing in healthcare for a lot of beneficiaries, right? CMS in round numbers oversees sort of the direct or quasi-indirect appropriation of healthcare dollars to about 165 million people when you include all of our program areas. And impacts, I would argue, everybody, because a lot of the policies and programs sort of apply even more generally than just people who are on Medicare or Medicaid or marketplace plans or CHIP or any of the programs that we directly or sort of indirectly run. But we have to be good stewards of those dollars. And the American people and taxpayers have a right to make sure that those dollars are spent wisely. Congress generally doesn't have the technical expertise or the wherewithal or the inclination generally to define in particular detail in an enduring way that will last over time how all of those programs should work in detail to make sure that we're spending those dollars wisely. And that's where some executive branch agencies, including CMS, come into play. And so the regulatory process includes a lot of notice and comment public rulemaking procedure where we'll put out proposed rules, seek public comment. Usually they're open for something like 60 days. And in general, most of us out there practicing clinically are not paying attention to the Federal Register. We're not, happening to, go and put in comment in that 60-day period for things that really have a huge impact on us and on our patients and on our communities. And so oftentimes there's a lot of reliance on our specialty societies and other organizations to pay attention to that, right? It tends to be, complex and sort of technical detail that requires people to be sort of following that all the time. But that ecosystem of practicing clinicians out there, the societies and organizations around them, and all of the other folks in the healthcare space, hospitals and all sorts of other organizations, right, collectively put in comment into that rulemaking process. And then as regulations get finalized, those are sort of the next layer below the statute that implement all of those programs that Congress sets up. And so sometimes it's frustrating often when I'm around chatting, particularly in rural hospitals, where we run into things that were created and sort of baked in as part of the original programs. Like we can talk about critical access hospitals in a minute, where some of the pieces are statutory and inflexible. Barring a change from Congress, some of the pieces are regulatory, and it's not that they're inflexible, but as you said, they take a long time to change because we have to go through that notice and comment process. And some things, even at the level of the regulation, still can create confusion or can be interpreted in different ways. And so there's sort of this other layer of guidance that we can put out to say, here's what we mean by that, or let's help clarify sort of what the requirements are here or there. But that's a long answer, but it is sort of this complex machinery that does take a very long time. As part of, as we've talked about, it's part of how it's actually really helpful to have access to people who spend, I have colleagues at the agency who spend, their entire career for, 20 or 30 years working on critical access hospital policy, for example. And so we can tap into some of those resources to try to figure out the right path forward for folks.
Yeah. And in the last several years, I've seen that process kind of unfold. And for someone like myself, I think, okay, I got a 30,000-foot view of this and what path we should go forward. But there are a lot of people with that vision. And it's a matter of melding those and seeing the process through two different organizations as helping to craft some recommendations, for example, for conditions of participation for rural emergency hospitals. It just came up in the past few years, just, a concept that had been on paper for a while, then suddenly emerged and passed through Congress on an omnibus bill and then gets thrust in your lap. And you're like, well, okay, well, what are those conditions going to be? But seeing that process unfold, the number of organizations that you look to for input, it's no wonder why something like that takes time to get it right. Because I can see there are certain biases with every organization you talk to, and really CMS is that central and most unbiased body that has to collect all that data and then try and create policy that's best for all, is how I see it.
Yeah, and I see it that way also, and I appreciate you putting it that way, right? Our job as career civil service people within the agency is to work on behalf of the American people, right? And so we represent the people of the United States in figuring out, on balance, on the whole, in the aggregate, how we are going to thread that difficult needle sometimes. And that, as you said, requires a lot of input from a lot of different folks. And And frankly, we don't get it right a lot of the time. And I think that one of the things that, as policy-minded clinicians, systems-minded clinicians, that we can always remember is that this is sort of an iterative process, and the current state is just a reflection of the inputs that we've had to date, the balances and trade-offs that have been managed to date, but there is no final state. It's always evolving, and it's an iterative sort of improving process. And so continuing to get new evidence, continuing to get new input and new feedback, and understanding what's not working. That's what I love about working at this agency, to be able to continue to move forward. Yeah.
Yeah. Well, and kind of steering toward our topic today, it really comes down to the quality of medical care provided at particular hospitals, and that's largely guided by training and experience of the emergency provider. Now, CMS recognizes physicians as well as PAs and NPs as providers that can be reimbursed for services. In urban hospitals, and we always talk about how can we gain parity in rural with our urban counterparts, but in urban hospitals, it's already been stratified that emergency medicine trained and boarded physicians work at those facilities. Those are the types of facilities that we've been trained at. We like the high volume, the use of our training in our procedural skills, et cetera. And so we've gravitated there, and we see a need for emergency physicians to be at the other 40+% of hospitals that are rural. Now, some of us gravitate there. About 8% are self-proclaimed emergency physicians. That doesn't mean they're EM trained and boarded through ABEM or AOBEM. Maybe, I don't know, 2%, we think are actually trained that way, that are in our lower volume EDs. And when we get to, so the stratification is at urban, we have those EM trained and boarded physicians. And despite having more residencies, the majority are still wanting to go to those facilities, even though that geographic flexibility is getting less and less in the job market. In rural, it's largely primary care providers and a mix of emergency physicians down to, I don't know, the 5,000 to 10,000 up to 20,000, 25,000 visits. You start to see that change. When we get down to what we call frontier critical access hospitals, less than 5,000, or some say 4,500, about a half patient an hour or something. When you start getting to that level, and then you start getting to extreme frontier critical access, and you're at some of those, we're reviewing some of those hospitals now. Where are you traveling in Wyoming?
Yeah, so we've been in our region through a lot of places, through rural Wyoming this week actually, and recently we were in North Dakota. I was in Montana just under a year ago, and have spent a bunch of time at many of those very frontier places. And just it makes a huge difference to be on the ground in a room with folks, and we'll never understand the day-to-day reality as well as people who live it do understand it. But it's certainly better than sitting in an office in Denver, Baltimore, or DC or something, and pontificating without the opportunity to go and see it for real. It's super valuable to see it for real. Yeah.
Right. And a lot of our EM colleagues don't see that, particularly those on ACEP Council. It's largely represented by people at large academic facilities. You've had an opportunity to see both. You're, you're in one of those facilities, and you see this, and it's hard to give that impression to council goers of what it's like in those facilities, what it's like for those hospitals to recruit, or those health systems to recruit that staff those hospitals. And as much as we all agree that we'd like emergency medicine physicians to be at all these hospitals, even the smallest of critical access hospitals, I just have come to the conclusion it's just not going to happen. There isn't a real interest on the physician to go there, but more so we don't have those numbers. And if we try to increase those numbers, all we're going to do is saturate the urban area. So what is that balance, and how in the end do we help those providers that don't have the advantage of having residency training in emergency medicine? How do we help them to be successful? More importantly, how do we help them to be confident and safe in their practice for these rural patients, so we can begin to gain parity? And this has been a big thrust of this podcast series, which gets to be a little controversial, but I just want to let's talk about the elephant in the room, which is that lower volume ED. We can, we've had as ACEP a collaboration with AAFP, which I think is terrific, and that'll handle those middle volume hospitals. But we have to talk about these lower volume EDs, which personally I believe is our most at-risk patient population because of the inconsistency of the training of these providers. And I just had two questions. One, if you agree with that, and two, what has been your experience going through the Midwest to these emergency departments? What percentage of those hospitals that are frontier critical access and extreme frontier that are staffed by PAs and NPs?
Yeah, there are so many threads that I want to tug on in what you just said, and so I'll try the first few, and then remind me about the ones that I missed, because there's so much in there. You're right on. I think in the big picture, the key workforce challenge that you mentioned, I think, is something that is absolutely front and center. It's inclusive of physicians, including specialty trained physicians. It also includes APPs. It also includes nurses, and lots of other clinician and non-clinician staff. But one of the things with specific regard to sort of emergency medicine physicians, as you asked about, is that there's not zero who are absolutely drawn to work in some of these communities. But it's not sustainable at scale, as you said, for a lot of reasons, and both the supply sort of challenge, and the consequence of, especially with families or spouses with other careers or kids, right? The consequence about having a real need to draw somebody into a community, if they don't have a pre-existing connection there, or it's not something that has always been a part of the fabric of who they are as a person. It's just very challenging for a lot of reasons. And so that's actually like the number one thing that I hear about in many of these rural hospitals, is the challenge of recruiting physicians, and also the challenge of recruiting non-physicians too. I think one of the things that, to directly answer your question about sort of APP staffing in emergency departments first, and then sort of back up into a couple of the details underlying that. It's very, very common to see what you described, which is that there aren't any physicians, perhaps even that work in the emergency department at all. That 100% of the staffing model is built around APPs, sometimes with a physician backup system or a on-call system, sometimes with a telehealth backup. Lots of different flavors that different communities find work for them. But it is certainly a place where we see some geographic differences, and really does become a health equity concern for us as an agency to view. And it's not just emergency care, but obviously in the context of the conversation today, right, to view these geographic differences in the access to care that people have, and into the concerns that they have about wanting to stay in their communities for care as well. So all that to say, something that we're acutely aware of as an agency, and it's one of the frustrating places where we don't really have a ton of levers. We have had the opportunity to expand GME slots a little bit, and as you led with, right, Congress sort of appropriated some additional money for additional GME slots to be phased in over 5 years. We're sort of right in the middle of that. There's a preference toward rural and underserved areas. To my knowledge, there have not been very many expansions of emergency medicine training in rural areas as a result of sort of those GME funds being available. But that's sort of one of the tools that CMS has in a limited toolbox around workforce. We have a lot of partner agencies across HHS, including HRSA, the Health Resource Services Administration. They have some funding programs. They're the ones that sort of run the FQHC program, Federally Qualified Health Centers, and often are very involved in rural grant making opportunities, rural workforce pipelines. So we partner and collaborate with other agencies. But we don't have a lot of great levers to be able to inject staffing into rural areas or to change the incentives in the way that our medical education system works, with the cost outlay that physicians have to incur to go to medical school, and all of the other consequences around sort of spending a career in a place that is outside of an urban area. And those are like really important societal factors that are outside of the scope of what we have power to sort of tweak very much as an agency. So part of what we've had to do is accommodate each community's needs assessment as they have viewed it themselves. And that's why a lot of the conditions of participation reference the hospital's written anticipated needs of its patients, and can have some flexibility in developing staffing models that work for them. There's opportunities for states to be more prescriptive. And so CMS will defer to a sort of more stringent state requirement. For example, there are states that require 24/7 physician presence, for example. It's not a requirement of a CMS certification program for cause or rural emergency hospitals, but we'll sort of defer to a more stringent state requirement. Otherwise, we're sort of setting the minimum floor, which does provide a lot of latitude for each facility to try to figure out, for the needs of its patients and its community, what's the right level of training, what's the right experience. And that, as you said a little bit ago, represents a tricky balance of not making the requirements so stringent that hospitals can't possibly meet them and then don't have the care at all for the community, and not setting the floor so low that it exposes the community to risk of low quality care, or care that wouldn't meet the standard that the American taxpayers would expect for investing their dollars in federal payment programs. But I'm sure there's a number of other threads in there that you can touch on also, and we can delve into more detail.
Yeah, well, I think one of the comments that a lot of physicians make is, if you would pay the physician, they would go there and work rural. And that comes down to the global budget at those critical access hospitals. So would CMS approve a global budget for a frontier critical access hospital that wanted to staff with emergency medicine trained and boarded physicians? Is that something that they could put into that at, it doesn't have to be extravagant. It can be, make it on par with what they would make in the urban setting. We always hear, oh, you can't, they can't afford to pay it. And, there is cost plus reimbursement at these rural critical access hospitals. One of the advantages to being a critical access hospital, and for people that don't understand, I'll tell you my understanding, and you can tell me if that's right on. But my understanding is you give up your right to do your own professional billing. You turn that over to the hospital. They bill separately, or I guess they take over that responsibility of the professional service, bundle it into their costs, and then you get cost plus reimbursement, which is standby capacity and the 1% plus for Medicare patients and the rest. So is that a myth that they could build into the global budget, or how is that approval process? And I know that's a big ask to have you kind of attack, but
Oh, no, it's okay. Yeah, the government-y sort of answer is it depends on how it's configured, right? But you're absolutely right that in general, the way that most critical access hospitals operate right now, right? The critical access hospital program's been around since 1997 or so a while, but not forever. By comparison, the idea of developing a prospective payment system, PPS, for hospitals, which is how we think of non-critical access hospitals operating, where in advance what you're going to get reimbursed for any particular service. That's been around since the mid 80s, like 1983, I think. And so critical access hospitals as a concept are newer than that, but you hit it exactly right, where the idea is cost plus reimbursement, which adds some complexity from sort of an accounting and structural standpoint. There are certainly some challenges in the nuances of the way that sort of all that cost reporting works for hospitals, and some pieces that are allowable and not allowable that we certainly hear good feedback on from critical access hospitals about what would be even better about that model, because it is a model that's 25 something years old. And so there's a very good question sort of right now about what does the future of the rural hospital look like? Does that CAW model still fit everybody, or are there modifications that are needed? And if those modifications are statutory versus merely regulatory, sort of what's the right path to do that? But that idea that you floated about sort of a global budget system is something that's outside of what the critical access hospital statute envisions, but it does include some opportunity with other mechanisms like the innovation models. And so the Affordable Care Act authorized the CMS Innovation Center, or Centers for Medicare Medicaid Innovation, CMMI. So you hear it referred to both ways. And there are a number of models that CMMI has proposed or accepted applications for that include some elements of that. Frankly, the uptake in rural areas has been relatively low. Sometimes, depending upon the model design, it might require cooperation across maybe an entire state. Sometimes it might be facilities that participate in sort of networks of other facilities. Many models exist, and only a few of them sort of touch this idea of hospital financing. There are lots of others. Some are for specific clinical conditions like dementia or renal disease. So there's lots of different ways. But the fundamental idea of models is that by participating in a model, it provides some flexibility to get outside of what would otherwise be a statutory constraint in the way that the law was written, and can sort of waive or modify some of those requirements for model participants. So that's the mechanism by which hospitals, or one mechanism by which hospitals could potentially participate in something like global budgets. And as I sort of said earlier, we haven't quite gotten that right yet, because we haven't really proposed a good set of rural models that have had a lot of uptake. But there's a lot of interest in that. And there's actually some upcoming events around the country that CMMI is hosting to try to get more input into sort of what does rural care of the future look like, and how do we support that in model development. There's also, we've sort of alluded to the idea of the REH, the Rural Emergency Hospital. There was this idea about maybe on the smaller or lower volume critical access hospital might want to do something like you've described, with sort of making prospective investments in staffing and maybe in other equipment and capabilities, like, for example, maybe a CT scanner or something, or places that don't have it, right? Like there are ways that you can envision a hospital saying, we have, every month this fixed expense to be able to operate the quality of care, deliver the quality of care that we want to our community, just to be available. And so the rural emergency hospital idea conceptually is CMS pays an infrastructure payment every month to be able to support some of that, the sort of keep the lights on and be available to the community work, and then pays a multiplier of the PPS rate. So it's not a cost plus reimbursement for the services that are actually rendered to Medicare beneficiaries, but it's 105% of what the fee schedule looks like, or the PPS rate looks like. But the catch for a lot of hospitals is no inpatient services anymore. You could still do outpatient surgeries and stuff. You could still do observation. And the way that the statute was constructed, it removes the opportunity to use swing beds. It removes the opportunity to participate in 340B programs. And so there are a lot of limitations where we've heard the feedback from many hospitals has been, we're right in between sort of a rural emergency hospital and a CAW. We would love to be able to evaluate that transition when we've run the math. It doesn't work for some of these other reasons. So that's like a great piece of feedback that for that one really has to sort of feed through legislation. But there's also a category of hospitals that are kind of between CAW and traditional PPS hospital also, where they're maybe a little bit larger. Maybe they need a little bit more than the 25 bed limit. Maybe that cost plus reimbursement model is really good for them. And if only they could sort of expand it sort of one little step further. And the statute really doesn't allow that either. And so that's also a place where we hear a lot of common feedback where, they're right in that volume band where it would be very helpful if we could have, another, full-time person, and that we could recruit them, as you said, if we were able to sort of pay a rate that's sort of commensurate with what they could get in a different market. But the cost plus mechanism for doing that doesn't quite get us there, because if we go to that cost plus reimbursement, we have to give up these other things. We have to be smaller, and then we're going to have this capacity constraint, or there's all these other dynamics, right? And it gets very local and very granular very quickly. And so, one of the things that we hear is that the spectrum of hospitals of the future might actually, be better to expand beyond sort of these three general categories of like a PPS hospital, a CA, and an REH. And there's maybe like a few in between categories that people are sort of interested in clamoring for. And as you led with, a lot of that ties into sort of what can be accomplished legislatively. They're not things that we can sort of open up as an agency ourselves, but they are commonly conversations that we're in to try to understand what the needs are.
Well, and I'm sure the Congressional Budget Office has probably the most difficult time figuring out costs under the CMS umbrella, since you don't know. I mean, you know what you've promised, but you don't know what what bills people are going to send in for various procedures and level of service. You might have a general idea, but if suddenly those global budgets ballooned up for all critical access hospitals, I would imagine it would raise eyebrows, and then you would have to look and see, is this something that we can justify? So is that kind of part of the equation as well, or is that?
Well, I think you're right. Yeah, all of us want to be good stewards of federal healthcare dollars, right? And we all know, and we've known for years, for decades, right, that we're on a trajectory, and have been for a very long time, of sort of an unsustainable investment in healthcare in this country, in a way that does not seem to deliver the quality that we would expect for that level of investment, is not on par with our peer nations, and the mechanisms by which we finance healthcare are so complicated, and we're talking right now just about federal payment programs, right? But most healthcare is funded through sort of an employment type arrangement with commercial insurance products. Also, some of those commercial products are actually now sold on exchanges or marketplace stuff, and so there's like all this interplay that is very complicated and is regulated on a state by state level as well. But you're absolutely right that sort of predicting, we have offices full of really smart people who spend their whole career sort of trying to make those predictions and evaluate the sensitivity analyses around the predictions. But it is very challenging to try to map out, if you change this one incentive or this one structure, what are the potential unintended consequences? If you squeeze the balloon over here, how does it expand over here? And where are the places where we'll develop effects that are not at all what we expected? Because in these complex interdependent systems, you get these strange feedback loops that are very difficult to simulate and model in advance sometimes.
So knowing that these global budgets aren't going to change suddenly as a result of this interview today, and knowing that we have a status quo that we recognize, and like I say, we just have to recognize the elephant in the room, that we have, through many states, given independent practice to PAs and NPs, and left them to self-regulate their onboarding. And there are many that are excellent. We've had many PAs and NPs that I've worked with help train that work independently in rural facilities, but essentially did a 10-year residency with me and my colleagues first, before they had that ambition really, and the self-confidence to go and work independently. That pendulum has swung a bit too far though, because now the rural or the urban large volume centers are flush with PAs and NPs often. There isn't that opportunity for them to train at a large volume facility, and many, as their first job, will go rural. And we haven't put up proper guardrails as to what that training is. And that brings us to conditions of participation for rural hospitals. And And we got a good look at those when we did the rural emergency hospital, because that gave us really time to scrutinize them and see if we wanted to have different conditions for rural emergency hospitals. In the end, it was felt that no one will switch to a rural emergency hospital from critical access hospital or do that conversion if you make the conditions of participation even more rigorous. So we got soft on the condition of participation of emergency medicine trained, but essentially what we found when we looked at this issue when I was rural chair through ASAP was, and on a rural task force in 2020, we did a survey broadly of PAs, NPs, and through the CALS organization, through ASAP, and we asked providers what it was at these frontier critical access hospitals. What was your condition to get credentialed at that hospital as a rural emergency provider? And in half the states, as an independently practicing provider. So no EM physician supervision, no family physician supervision. As an independent provider, what were your requirements? And it was ACLS, ATLS, and PALS. And we know that that doesn't make you an emergency provider by any stretch. That represents a very small percent of the patients you're going to see. What happens with pediatric fever, OB patients, with, with any number of things, eye injuries, even a sore throat. What prepares you to work there? So we've left it upon these providers to figure that out. And under the condition of participation for critical access hospitals, it has been left kind of loose because traditionally it's been physicians that have sought credentialing there and been working independently. And in the meantime, we've seen a swell of the need for APPs to work at those facilities. And again, oftentimes they trained at large volume facilities, but now we're seeing more and more that these hospitals are getting desperate, as you're saying, to get coverage. And we've left it up to those individual hospitals, to contract management groups, to local physician groups, to the community, to, to whoever, but in the end, that hospital credentialing criteria is pretty meager for what really needs to be. And has there been a look at that condition of participation, and could that be modified to be more specific or give more detail of what would be required of these providers?
Yeah, it kind of takes us back to the point about, the current state is just the current state, and lots of things are possible, and care evolves, the environment evolves. So I think, what I would say is that the question of scope of practice for any given provider type really is a function of state licensure laws, right? It's not something where CMS has an opinion or gets to directly weigh into the question of, which types of people have which scopes of practice with which level of, supervision or affiliation with somebody else. And in general, the conditions of participation and sort of CMS policies in that area sort of defer to the state where they're practicing on those types of questions. But you also sort of raise a great point about sort of the way that we interpret the relatively broad language of the CMS conditions of participation. One, side caveat, and listeners may be working at facilities or involved in facilities that have accrediting organizations that do what people call deemed status, which is to say the organization comes in and surveys sort of on behalf of CMS, and the Joint Commission, DNV. There are many others that are sort of operating in the rural space as well. I don't mean to endorse or list only a couple specific, but those are sort of common ones that people know about. And those organizations may have different, more stringent standards than just the CMS conditions of participation. So I say that as a sidebar because some of this conversation pertains really to the highest level of the way the CMS conditions are written, but other accrediting organizations that are operating on our behalf may be more stringent than those or have more detail. But in general, the sort of broad language, you're right, leaves it very much to the hospital to decide. And frankly, many hospitals, I hear this directly from hospital CEOs, many hospitals say, I don't have the in-house expertise to be able to define with precision what's the exact training required. My medical staff governance process is the same people who are working in the hospital. We don't have a large medical staff where there's a bunch of people who can spend a lot of time on doing credentialing and evaluating the backgrounds of each of our physicians. It's all the same people who have to be out seeing patients also. And we just don't have the ability to understand in sort of the nuanced depth required. What are the anticipated emergency needs of our patients in our communities? How do we match the right level of training to meet that? What are the ongoing education requirements that are sort of as a hospital requirement above and beyond, what the state might require for licensure or something? And so there's a large role to play for other organizations and specialty societies included, right, in both advocacy work, as you said, for saying, hey, let's try to evolve the standards, but also in helping support the clinical and hospital community out there as they sort of struggle with some of those questions where they have a million things that they're thinking about every day and trying to keep the lights on and run the service for their community, only one of which is the set of personnel standards. And they view it as integrated and important for the rest of their mission and their operations, but sometimes they really just lack the support. And so the toolkits and other support that's available from other organizations are very helpful there. And I think the last thing I would say about sort of evolving the conditions generally is that that's a great use actually of notice and comment rulemaking. There are places in proposed rules sometimes where there may not be a direct question of, what do you think of this specific condition of participation that has been on the books for 20 years? But as there are modifications of the conditions or as there's other proposals in rulemaking about critical access hospitals or rural emergency hospitals, commenters can provide comments about how an idea could be a logical outgrowth of what's being asked in the notice. And so there are mechanisms where people can put in those comments officially. And over time, that's how we end up proposing new standards. There are right now out for comment, and we can put this in show notes if there's links and stuff for your listeners as well who are interested. There's proposals around conditions of participation for OB services. That includes critical access hospitals and facilities that don't advertise having in-house OB capabilities. The idea being that we have to set a minimum standard for sort of what should be expected for acute maternal care and obstetrical emergency care, including equipment and sort of training, even if you don't have an in-house OBGYN, for example.
Right.
And so that's an example of something that we've heard from the clinical community is like, we don't really have a clear standard here. And that's now out as a proposed rule open for comment right now.
Yeah. And there are advocacy organizations, SEMPA for the PAs, AENP, just to do a shout out to them.
Mm-hmm.
They get it and they're developing additional standards. And the certification board for nurse practitioners said, now it's been a couple of years ago, that there isn't an NP program that you can graduate from that prepares you for emergency medicine, and you should get additional training. And so there are organizations that outline that path to be a safe provider in a rural community if you're going to be working independently. Unfortunately, my understanding is that there's only a minority of NPs that are members of AAENP, and are going to follow those policies, and that's unfortunate. And I think SEMPA membership isn't, doesn't represent all emergency medicine PAs either. And so how do you bring some regulation to it so people get on the same page, and you assure that you aren't going to get someone that isn't following recommendations of these organizations working at those facilities and just waiting for the next disaster? Because it will happen, and that's really the fear that as an outsider, looking at these hospitals, you don't know who you're going to get from one day to the next, and that's a concern that is brought up by physicians and emergency physicians, and some look at it, just shake their head and say this is outrageous. So kind of turn to, first the health system or that, individual critical access hospital. But, then, is that something that can be driven federally by CMS and have some kind of mandate. And that's what comes down to that condition of participation. And that's where conversation commonly goes. How would we start that process and have that looked at so that we can have an assurance for rural patients that everyone has someone adequately trained, or at least has had some minimum standard of training?
Yeah, as you said, it's a tough policy question with trade-offs, right? And there's consequences either way, right? The current state talks about the medical staff at a particular hospital establishing the guidelines, delineating qualifications, what people have to possess to be granted privileges for provision of emergency care, about being under the direction of a qualified member of the medical staff, right? But what qualified means is up to the hospital and not up to CMS in that context. And the policies and procedures that a hospital has for how they develop their emergency services, right? And they're their own policies and procedures. So is there a role for federal regulation there? That I think that you're talking about something where there's room to improve conditions of participation based on feedback of the clinical community, and encourage you to use the sort of rulemaking notice and comment process that's out there now, and also sort of in the future to do that, and others who are doing that. It's also, federal is not obviously the only layer of regulatory oversight that we have in healthcare too, and so there are states that have started moving in the direction of sort of having more stringent staffing standards in emergency department settings as well. And that obviously is a tricky spot for federal government to be in as well. We want to make sure that part of the reason that sometimes the standards are written the way that they are is because they have to apply broadly as a minimum floor everywhere. And sometimes the trade-offs of having something more specific have been that it creates too many consequences of eliminating access to care or reducing access to care in a way that's unintended when you do it at scale. And so all of those things, and as you've alluded to, there many constituencies involved here who all have varying opinions and varying sets of experiences that are all valuable. And that's, as you sort of led with, one of the tricky places of being a steward of the public resources as an agency for us is sort of balancing all of those trade-offs. But I think the specific answer is most things are changeable, and really does require sort of the rulemaking process and public comment, and things can evolve over time based on input. Yeah.
So there's a season or a time interval every year for public comment. Is that coming up, or is that now?
It's happening right now. The particular month that it happens, or a couple of months that it happens, vary a little bit on what you're talking about.
Okay.
But for the outpatient prospective payment system, and the fee schedule that's included in that, as well as many of the other policy elements, which also includes some things like telehealth and lots of other pieces that are important. That happens to be occurring right now. It usually ends up that in the fall to early, wintertime, end of the calendar year, November-ish time, those final rules get published. And if you sort of back it up with time to evaluate all the comments, the 60-day period to actually have the time open for comments, that usually means that around summertime is when some of those proposed rules are released. It's coincident timing wise with the physician fee schedule right now, which is sort of the outpatient for Medicare Part B fee schedule that physicians get for billing their services. So both of those are out for comment right now. And in general, there's an opportunity for the comments that occur during any of those processes to also be used within the mind of the folks within the agency who are working on it to inform what do we propose next year or the year after that. And those are all places where it's really important to get input from the clinical community and from each of these constituencies involved. And the idea being that if you can draw a connection between things that are proposed right now and right now, for example, there's not a proposal to change the CA emergency services condition of participation. Yeah. But there might be a logical outgrowth of proposing that in the future based on comments that we receive now. And so long way of saying participate now. The societies and organizations know about these cycles too and are participating, but we really do love getting comments, even if it sort of is not directly pertaining to the specific technical details that are proposed this year, we're still listening to those for the future rulemaking cycles.
So is there an actual interval of time during the year, or can you send in comments anytime, or advocacy organizations can send them in anytime?
You can send in feedback anytime, and we often have meetings with advocacy organizations, and oftentimes they'll have a particular set of agenda items that they want to talk about, and we can get the right, if we know that in advance, or we can get the right policy folks who work in that area to be at the meetings and sort of discuss the specifics. So that happens year round and all the time. For these notice and comment rulemaking opportunities, that is on a sort of a 60-day cycle once the proposed rule goes out. But anytime people can reach out to us and we can set up conversations. We have a web form that sort of makes available a few of our different components within the agency. And frankly, that's a large part of what we do as the cadre of regional chief medical officers, is from the clinical community, help understand and sort of triage some of those requests to figure out the right folks within the agency to connect people. And many of the larger national organizations have standing meetings with many of our policy folks who sort of work in the areas that pertain to that national organization's work. So there's a lot of different avenues, but we definitely want more and more of that level of engagement.
Yeah. So kind of to wrap up, where do you see CMS making changes right now, looking at the rural communities and where you are now? What ideas come to mind? And maybe there are things that are already in place that you're trying to change. But are there any projects or initiatives that are, that you see that could help where you are right now, looking at these Midwest, critical access hospitals, particularly those low volume facilities?
Yeah, across the country, rural health is a major cross-cutting initiative across our agency. So that means each of the different components within the agency are sort of responsible for making sure that they take geographic and rurality sort of considerations into account as they're developing and thinking about programs. So the work on models, CMMI models, we've sort of talked about a little bit, but there are a few and more work coming on understanding sort of rural there. There's a lot of places where the telehealth flexibilities that were helpful as part of the COVID-19 public health emergency are set to expire by statute the end of 2024. Many of them we've been able to extend, but there are some that require legislative change. And so we have put right now, as part of those same proposed rules that we were talking about earlier, we've put sort of a framework out for what are the things that we have the authority to continue to extend or make permanent. What are the things that would sort of change or revert back if there wasn't a statutory change? So we've sort of built the you could think of it as like a pro forma of like what the regulations would look like if the statute reverted back. So that touches sort of rural care a lot. There's a lot of work underway on many of the things that also impact larger or urban hospitals in access to emergency care, boarding and crowding, and sort of hospital flow problems, access to emergency care at all, meaning EMTALA and sort of the medical screening, exam, stabilization, transfer requirements that are sort of core to that. Lots of work in many of those spaces that also I think are really important in rural areas. And making sure that all of, every community has its own unique challenges. And sometimes, as we sort of talked about at the beginning, going and visiting and understanding what some of the nuanced challenges are in a particular area actually leads us into not these big sweeping wholesale, massive policy changes, but tiny little tweaks for somebody that makes a big difference for that community. And it might be as small as, hey, did you notice that on our cost report, we keep having the same errors show up? And it's just these small sort of technical things sometimes that make a really big difference, and sometimes make the difference between being in the red or being in the black for a hospital in a financial statement. And so a lot of our work is about being out and listening and being available and being real people who can sort of get access to the information and sort of break down barriers as hospitals are experiencing their own sort of local, hyper-local factors and environment too. which kind of brings us full circle to the idea of staying in touch and having people at the agency that that folks can reach out to as they're thinking about these issues and as they're running into stuff also, which is the most wonderful part of my job, to be able to hear what's going on and try to be as helpful as we can to connect folks and be a good switchboard operator, as one of my colleagues likes to say, with connecting folks across the agency to people who are out on the front lines living it every day.
Yeah. Well, it's great to hear you're having such good experiences going around to these hospitals. When you are first a medical director in a large facility, you hear the feds are coming, and it's like, oh my gosh, we have to get our refrigerator temperatures right, and we got to get our sandwiches out of the med fridge, and no
It always
eating
takes a little bit. Yeah. When we show up, we have to do a little bit of convincing that we're not here to survey. We really are just wanting to know what's going on. And I should say, right, all the other regions around the country, there are 10 HHS regions around the country. Everybody's doing rural road trips. They do it every year, and there was a little bit of a hiccup during COVID where we didn't go in person. But it's historically an important part of the agency's work, and so colleagues around the country are doing the same thing. And we really do want to be out there, sort of understanding the landscape.
And a big part of our ACEP Rural Task Force recommendations was the availability of telehealth to all these rural facilities. So the fact you're extending that is much appreciated as well, because those providers, I'm sure you recognize, need that support, and particularly those that are less experienced need to lean on emergency physicians on the other line or on the other side of that monitor to help them through processes and really provide safe care in those communities. So that's hats off to extending that. So
as a country, as a system, I think we've all understood a lot more about telehealth going through the COVID pandemic, and that one of the silver linings is the opportunity to be able to extend some of those things that really kind of occurred as a natural experiment initially with waivers and flexibilities, to realize that actually they enable tremendous improvements in access to care. So we really tried hard to make sure that we understand what those advantages are and do everything possible to continue them where we're allowed to.
Yeah. Really try hard to find a silver lining with COVID, but all right.
Yeah. Yeah, fair enough.
We'll give you that. That's
fair enough.
great. So, well, good. Any last comments, Sean, from CMS, or did we kind of touch on it? I know it was a little taxing, kind of trying to explain all these nuances, and it's a complicated organization, and we've only scratched the surface,
Exactly.
but
Exactly. We've scratched the surface. Yeah.
anything
Thank you.
anything I was remiss with, or did we think we covered it pretty well?
Well, yeah, thank you for having the conversation. And I think that I would say for folks who are listening and involved in this space, right, stay in touch. We really do want to get your feedback. We really do want to understand sort of your perspective and your ideas, because there is no magical they sitting in a building somewhere who know better than anyone else. It's just it's a bunch of people who are trying to serve the American people. But really the information that we have is only as good as the information that we get, and that informs the decisions that we're able to make and the recommendations we're able to propose. So we really do value the feedback, the conversation, and thanks for everything that you're doing out there for patients and for communities and for advancing the cause.
Yeah, and thanks for joining me. It's been enjoyable to talk with all of the advocacy organizations that I have, the educators, telehealth, all those people in this space. They all have an interest in safe patient care and want to provide that. And that really is the center of it. And big part of that is because that's part of wellness. No one wants to have yourself or any of your colleagues out there not being confident caring for people, not having resources available like telehealth as a backup to help you, not having an EMS system that can transfer that patient when needed. The last thing you want to do is be hanging on to people that shouldn't be at your facility as well. So there are many layers to this, but all the advocates, administrators at large health systems, small critical access hospitals, they work with what they have and provide this great care as best they can. But more and more, it's getting recognized that the training of these rural providers is paramount, and I think we are seeing a greater standard start to evolve for onboarding and all, despite not a global mandate. But I think it'd be worth having that discussion at CMS about a condition of participation as well. And I'll talk to different advocacy groups and see if they're interested in putting in a public comment and perhaps going down that path.
Thank you for everything you're doing, and for all the listeners. Thank you for everything that you're doing out there as well.
All right, great, John. Appreciate you coming on, and we'll stay in touch, please.
All right, thanks, Steve.